Okay. I think maybe we start. Good afternoon, everyone. Thank you for coming to this session. Um, the name of the session is Mortality Statistics and Health Outcomes. Um, the the utility of mortality data depends largely on accuracy and completeness of causes of death reporting. The basis of which is the accurate completion of the death notification forms by doctors, alignment with the ICD um, as standard. Accurate mortality also helps authority identify leading causes of death, to track trends over time and allow effective health planning and allocation of resources. I think with that introductory few words, maybe just a bit of housekeeping for our esteemed presenters. Each presenter will be allocated 10 minutes. In the case where the speaker is below the 10 minutes, we can then allocate time for 1 or 2 questions. Otherwise, we will move all the questions to the end of the session. Okay. I'm helped ably by Tanya. She'll also help me with the timekeeping. Okay. Maybe to start off, let me rather read all the bios so that we get that out of the way. Then once we start with the presentation, then we can just move. Okay, we have 5 presenters. Yes. The first presenter is Professor Tom Moultrie from the University of Cape Town in South Africa. And his topic is, what did South Africans die of during COVID? Professor Moultrie works for the University of Cape Town in South Africa. After completing his undergraduate degree in actuarial science, he worked for several years in the industry developing epidemiological models of the spread of HIV in South Africa and evaluating the impact of diseases on the life insurance industry of the country. Increasingly being interested in demography, he studied a master's in developmental studies and a PhD in demography in the UK before returning to South Africa. He has been based in the UCT for over 20 years, and his work has focused on 2 principal areas: demographic estimation from limited, defective, and deficient data, and the trajectory of sub-Saharan African fertility decline. He led the team of international demographers that in 2013 produced the tool for demographic estimation, an online resource that most of us demographers use today. More recently, his work has been dedicated to the estimation of excess mortality from COVID in South Africa, working with colleagues from SAMRC. He has also worked with ESCAP on producing material to assist countries in estimation of completeness of their CRVS system. And Professor Moultrie will be joining us online. Our second presenter is Dr. Hosniera. Okay, I'll get better. Hosniera Pavan from the Institute of Epidemiological Disease and Control and Research. Dr. Hosniera Pavan is currently working as a fellow at the Institute of Epidemiology, Disease Control and Research. After graduating from the University of Dhaka, Dr. Pavan worked as a medical officer under the health services of the People's Republic of Bangladesh. Subsequently, she joined IEDCR as a fellow and is currently pursuing a master's in applied epidemiology under the Ministry of Health and Family Welfare. Her work includes outbreak investigation of pufferfish poisoning and lead poisoning. Okay, sorry. Evaluation of medical certification of causes of death and analysis of MCCOD data from 2020 to 2024, as well as snake bite poisoning related death analysis. And she is with us here. Our third presenter is Mr. Long Guyan Tan. I hope I I did well. Okay. From Hanoi University of Public Health. Mr. Tan is a public health researcher at Center for Injury Policy and Prevention Research, Hanoi University of Public Health in Vietnam. His work focuses on injury prevention, road safety, community-based public health interventions. Long has contributed to several national and international research projects, collaborating with organizations such as the Johns Hopkins University and Bloomberg Philanthropies. His experience includes project coordination, data analysis, implementation of evidence-based intervention. His research focuses on improving road traffic injury data accuracy in Vietnam through multi-source data integration to support evidence-based policy. The fourth presenter is Dr. Stanislaus. Okay. Is it okay? Okay. From the Department of Public Health and Preventive Medicine in India. Dr. Abhishek. Okay. Dr. Abhishek is the state nosologist with the Department of Health and Family Welfare, Government of Tamil Nadu in India. His work focuses on strengthening CRVS systems, particularly improving causes of death certification, mortality data for state to have better public health planning. He is actively involved in initiatives to enhance the causes of death, information of the state in collaboration with various organizations. Our fifth and last speaker is Mr. Yeho from Makerere University Center of Health and Population Research. Mr. Yeho is a biostatistician and research scientist at Makerere University Center for Health and Population Research, with over a decade of experience in research, methodological design, advanced health data analytics. His work is deeply aligned with civil registration and vital statistics systems in mortality estimation, causes of death determination through verbal autopsy, and population cohort demographic analysis. He is a cohort fellow, cohort 2 CAT 2 fellow of the CRVS Applied Research Training program under UNICA, reflecting his formal commitment to strengthening CRVS research and practice across Africa. His technical expertise in longitudinal data, survival analysis, machine learning, geospatial analytics, and supports the generation of high quality population level data essential for robust CRVS frameworks. He designs real-time interactive dashboards that translate complex health data into actionable public health intelligence, actively applies advanced statistical methods to inform evidence-based decision-making. MCAO is dedicated to building the analytical capacity needed to advance CRVS throughout Uganda and the wider region. Okay, thank you very much for the attention. I think we'll now move to the first speaker. As I indicated, it is Professor Moultrie from the University of South Africa. Do I need to activate him? Oh, and he's online. It's a recorded presentation. Okay.
Good afternoon, and apologies for not being able to be in Bangkok to present this paper in person. I will, however, be online for the Q&A session after. As an organization, SCAP and the team led by Dr. Petra Nechmias is particularly dear to my heart, and I congratulate them for the inspirational efforts over so many years in seeking to improve CRVS in their region and leading by example worldwide. The paper I present today is a collaborative one between colleagues at UCT and the South African Medical Research Council. The actual paper title is somewhat longer, but the essential thrust of this paper is captured by the title on the screen. What did South Africans die of during COVID? By means of background, in January 2020, alert to what was being reported from China and Italy, we started to ask what our contribution might be to what seemed to be an inevitable pandemic. In South Africa, even though testing for the virus was widespread, around 8 million tests over 3 years, we were never able to work out how to convert those data into national, reliable, validated measures of either incidence or prevalence. Likewise, in South Africa, we have a dual-track health system, a well-resourced private sector and a much less well-resourced public health system. We understood that our health system would not be able to collate or disseminate reliable, real-time data on hospitalizations or morbidities, which left the deaths as the only likely peg in the ground which we could use to establish the consequences of the pandemic. To this end, we repurposed the system that we had developed during the early years of the HIV pandemic, and using first weekly and then daily data from our National Population Register, which only covers South Africans either by birth or naturalization, to provide estimates of excess deaths and numbers of deaths by week, by age, sex and type of death classified as natural or unnatural causes. To render these data nationally representative, they had to be adjusted to allow for both the fact that non-South Africans are not captured on the register, their deaths are processed separately later, and for what we know to be a less than complete civil registration system in the country. During COVID, South Africa was amongst only a handful of countries in the global south to be able to monitor deaths in near real time. And our paper has two aims. First, to compare our estimates of excess deaths from natural causes with the official data from the CRVS system, covering the period up to the end of 2022, which data was released in mid-2025. And second, to assess the coded causes of death to identify those causes giving rise to the excess natural deaths that occurred during the pandemic. The principal data we use are mortality and cause of death data, MACOD, in effect our mortality CRVS data, released by Stats South Africa in the second half of 2025, and which provides unit record data of deaths notified, including those of non-South Africans, through the end of 2022. We describe two investigations. The first is to validate the real-time surveillance system we created during COVID with the full data from the CRVS after adjustment for incompleteness. The second investigation is perhaps more interesting. The MACOD data provide algorithmically derived underlying causes of death, so we can see finally what people in South Africa died of during COVID. To do this, we first identify particular ICD-10 codes that show a similar pattern by week as the COVID deaths. And for those particular codes, and for the other causes grouped into ICD-10 chapter codes, we derive a cause, age, sex, week specific counterfactual of the expected number of deaths using a negative binomial model. The results of the first investigation show that we were remarkably successful in our attempts to build a real-time mortality monitoring system. The figure on the left shows in blue the number of deaths estimated by the SAMRC UCT collaboration in near real time. In red and barely visible since they're so close to the blue line are the MACOD deaths released in 2025 after adjustment for incompleteness. The four waves of COVID mortality are obvious. The dashed line shows the unadjusted MACOD deaths, while finally the black line shows the baseline expected weekly deaths, which we derived, showing a seasonal pattern coincident with our somewhat colder winters in the middle of each year. On the right-hand side on the table, after adjustment for incompleteness, the MACOD data report 1.66 million deaths over the 3 years of the pandemic. The real-time system had estimated 1.67 million deaths, a difference of around 12,000 deaths, or 1% over the 3 years, with the bigger differences being in 2021 and 2022. All told, we can see from the MACOD data an estimated 283,000 excess deaths over the 3-year period, compared to the 295,000 estimated by the MRC. As can be obviously seen from the data, most of those excess deaths were in 2021, about 40% or 42% higher than that year which had been expected in that year. By contrast, by the end of 2022, the observed number of deaths had started to trend very closely to what we had expected. A 10-minute presentation slot does not allow us to present the results of the second investigation in any detail. That's provided in the paper, including, importantly, analysis by age. But here we show the number of deaths at all ages from particular causes by ICD-10 code in blue, and the modeled cause, age, sex, week specific counterfactual expected deaths presented in red. Some causes of death show a seasonal pattern. For example, the respiratory diseases and the ICD-10 chapter 10 deaths. Others, cancers for example, do not. Deaths from disease of the blood, that's ICD chapter D, track the expected numbers really closely. In contrast, observed cancers are far below those expected. It's a point to which I will return later. Infectious diseases at the start of the pandemic are also much lower, which was when the country was in a hard lockdown, thereby limiting the transmission of infectious diseases. Other causes, for example, diabetes, hypertension, flu, and poorly specified causes, show patterns strongly similar to those actually coded as being from COVID. Also, we can see that some causes clearly found favor as an underlying cause of death in some waves, either lower respiratory tract infections in waves 1 and 2, heart failure, for example, at the end of wave 4. Finally, there are some distinctly odd elements to the data. For example, the sudden rise in diabetes deaths at the end of 2022. We are convinced that this is an algorithmic coding error, as this rise in diabetic deaths is very noticeable amongst very young children who do not tend to die from diabetes to any great extent. We can summarize our results in a single but very busy table by means of using the p-score, the proportional excess mortality, by age, year, and causes of death. We split the causes of death into those grouped causes that did not show a pattern similar to COVID, and the specific causes that did show a COVID pattern. This split is significant. The color coding in green shows causes with observed deaths less than expected. The red colors, which are largely in the COVID-associated causes, show deaths with more observed deaths than expected. In 2021, non-COVID causes in aggregate were some 6% lower than expected, while the COVID-associated causes were 75% higher than expected. And over the full 3-year period, those causes without a COVID signal were 6% lower than expected, while those with the COVID signal were 39% higher than expected. We can see substantial variation in excess mortality by age and by cause and by year. In summary, the SAMRC UCT Rapid Mortality Surveillance System provided an incredibly accurate real-time picture of deaths occurring in South Africa. We are fortunate to have a long time series of data from the National Population Register to work with, but our great constraint is not having cause of death in real time beyond natural or unnatural causes. The analysis of cause of death confirms the burden of deaths during the COVID waves, but a very complex relationship showing the effects of competing causes of death and perhaps also systemic failures within the healthcare system, which allowed cancer deaths, for example, to perhaps go unnoticed and undiagnosed. There's lots of further work which we require here to untangle and more comprehensively unpack the competing causes of death, and we need to convince ourselves that completeness is independent of cause of natural death. And finally, we want to look at the causes of death and excess deaths within each of the COVID waves. The main limitation of our work lies in the fact that these are new data released in 2025 for 2022. This is not good enough to be able to intervene epidemiologically and points to the need for electronic capturing of death notification forms and algorithmic encoding of cause of death in real time. We also need to redouble our efforts to improve the completeness of our CRVS mortality data. I thank you for your attention to this presentation. I will be online later to answer questions in the Q&A, but if you do have particular questions, please do raise them then or direct queries to me at the email address shown on the slide. Thank you very much.
Okay. Okay, thank you very much, Tom. I understand that you're online. Maybe we could just take questions for Tom specifically, because we don't know how much time he has. Any questions? Okay, maybe I could ask something. Okay, Prof, I wonder to what do you attribute? I know you said maybe there was no during the COVID time because of lockdown, you had fewer infections because of the restricted movement. But one of the things that I thought was that given our HIV burden, that during that time, you are likely to see a higher mortality from HIV. But I see the finding is of the opposite. But also I wanted to find out from you, what is the impression of the decline in the cancer, given the weaknesses in our health system around cancer management in the health system? Thanks. I hope you can hear me.
Yeah,
Tom.
Yeah, thank you very much, Tsiri, for your questions. They're very good questions. The first one about HIV-related deaths and infectious diseases during lockdown. It's also tied to the second question about which you asked about cancers. And really, I think there are multiple forces at work, and the paper draws attention, and in the limited time I had, try to draw attention in the presentation to, as well as this idea of competing causes. During the hard lockdown, I mean, obviously people struggle to access any form of healthcare, for chronic diseases, and that might well have had an implication for people on chronic TB or HIV treatment, for example. But those hard lockdowns were of fairly limited duration, and when we looked at specifically at HIV as a kind of showing a COVID signal, we did not see that that the HIV deaths came through. In other words, people with HIV were not being disproportionately dying from COVID. We did see, however, slightly elevated deaths from HIV, which might well be a function of people who are on chronic treatment not being able to access that treatment over an extended period of time over the pandemic because of difficulties and overburdening of the health system. Similarly, on the cancer deaths, it's not perhaps surprising that the number of cancer deaths was far lower than historically expected. And that's because really what I think is going on there is that, while the health system was overburdened, people were either not being diagnosed or treated, or in fact, even kind of recognized as having cancers. And so, I think that, what we see in some ways with the excess deaths for other causes might be people who actually were sick with cancer, would have normally have had cancer as an underlying cause, but because that was never diagnosed, it came through as some other cause of death. And so I think part of the story we're telling here is that when you try and dig down into the causes of death during the pandemic, yes, there are signs of that people died from causes other than COVID. We see from diabetes, hypertension, things which we knew people were dying of during COVID. But there's also a very complex relationship between competing causes of death, the effects on the healthcare system in the country during COVID, which actually makes this a much more interesting and probably more difficult combination of things to untangle, and that there's no quite simple, clear answer as to what actually happened during COVID, and that in some ways this paper is a warning saying that these effects are complex and very difficult to untangle. But thank you very much for your question, Matsidi.
Thank you very much, Prof. Okay. Thank you very much, Prof. Thanks for attending the session.
Just to note, Matsidi, I will be on for the rest of the session, and so if there are questions at the end, I will be around to answer those as well. Thank you.
Okay, appreciate it. Okay. There's a question. Should we take it? I think this.
Okay, there's a question online. I'll just read that out. It's from our colleague Bhaskar Misra at UNICEF. And I think it's similarly related to this issue we just discussed about contamination. How did you handle the contamination between deaths due to respiratory failure and COVID deaths, as a significant proportion of COVID deaths may have been coded as respiratory deaths? Was there an increase in respiratory deaths during COVID? Are data sets available online? It's for you, Tom.
Thank you. Again, again, this points to a problem in nosology, the coding of causes of death during COVID. For much of the pandemic in South Africa, the official version of the national government was that the only deaths from COVID were those which were identified, tested, as having been infected with COVID either before or immediately after death. And during the pandemic, we were at pains to point out that lots more people were dying than were coming through from the COVID deaths. And in some ways, what we see in the paper is exactly that. So there are deaths, excess deaths from diabetes, hypertension, for example, which we know were cofactors for COVID-related mortality. And so in some ways, this is a validation of our original argument that people, that the purely diagnosed, identified COVID deaths was a grotesque underestimation. Probably about 3 times fewer deaths than we actually observed were actually coded as COVID relative to the different waves of the mortality we saw. But of course, not all of those respiratory deaths are going to be COVID. And I think that this again points to the fact, and this is why our starting point was to say, let's identify those causes of death which had a pattern associated with the COVID deaths. In other words, by time and the duration of each wave of the pandemic. And we can see that certain causes did show a pattern similar to that. But we also saw, and we talk about it more in the paper, that we see what we call nosological clustering. That when doctors were being asked to fill in death forms in huge piles in hospitals, they seem to kind of coalesce around a particular cause of death in different waves, and that's not necessarily the true underlying cause of death. But if you had to fill in 30 or 40, 50 of those death notification forms every couple of hours, people would just say, "Oh, okay, this time we're going to say it's I-52 or some respiratory disease," and the other ways that they'd latch onto another cause. And so again, kind of what this points to is that with properly coded cause of death, or as an algorithmically coded cause of death, one can get a whole lot more information and data, but it is still quite complex to untangle what those causes are, how they relate to competing causes, how they might relate to other failures in the healthcare system. And so this is not something which there's a one and done answer for. This is something which actually other countries might be interested in trying to pursue in their own time to actually try and understand what the burden of COVID deaths was. And this is a starting point for an investigation which is going to keep me busy for a very long period of time. So thank you.
Okay, thank you very much for the questions, and thank you, Prof. I think we move to our second speaker, Dr. Pavan. Dr. Pavan study is climate-driven analysis of snake bites mortality in Bangladesh, 2020 to 2024. Just go ahead.
Good afternoon, and apologies for not being able to be in Bangladesh. Good afternoon, and apologies.
Take my greetings. I begin with a story in my life behind this snake. During my governmental posting in northern Bangladesh, I lost a young patient to snake bite because antivenom wasn't available that time. Issuing her death certificate is a pathetic for me. It's motivate me how I can explore prediction and guide preparedness and timely antivenom distribution. I am Husnaira Parveen. I am working at Ministry of the Health at Bangladesh and as a fellow, Institute of Epidemiology, Disease Control and Research. Today, I will present findings of temporal trend and climate sensitivity mortality of Bangladesh. Now, I acknowledge lots of institutions such as the SCAP, ECA, and in my institution, IGCR for technical guidance and MIS for access, give me the access of data for surveillance and Ministry of the Health for policy, planning, and my mentor, supervisor, all of the staff. Actually, snake bite envenoming is a neglected tropical disease, especially in low resource setting, and can cause a significant mortality and long-term disability. In Bangladesh, the burden is concentrated in rural and agricultural setting because human and snake interaction they are more frequent. However, the true magnitude is likely to underestimated due to the gap of surveillance or death reporting or any other lackings. Snake bite is not a random event. It is strongly influenced by environmental factor such as the rainfall, humidity, temperature, snake behavior, and human exposure pattern. Despite this, there is limited evidence how climate variability influence those snake bite. So, my aim to address the gap and assess the temporal significance and pattern of snake bite and prediction of the snake bite, and finally distribute the antivenom accordingly. Actually, I use secondary data for this. I get this access from the management information system of DGHS under the Ministry of the Health. Uh, we assess finally two types of analysis, one distributive and finally analytical, and measure the frequency, distribution, demographic pattern, and collect data from NASA power for humidity, temperature, and rainfall, and map spatial variation, use standardized incident ratio. And then I go to the Sarima model, seasonal auto-regressive moving average model for the prediction 2 years after. Here, statistical analysis, we use the Poisson linear regression, which produce the incidence rate ratio. Uh, Now the waiting section of result. Finally, I get data access of 7.5 lakh from the mortality whole of the Bangladesh from 2020 to 2024. But we extract the snake bite data where in 2020 to 2024. In 2020, 56 deaths are reported, and 2021, 56, then 97, and after 120, finally 42 days are 420 deaths are reported under the DGHS. I want to tell that it is the data from medical certification of cause of death, only the institutional death we cover. And we see that the young group, especially adult group, are more vulnerable for snake bite, and male person are more vulnerable and have a seasonal variety such as the monsoon season, especially in Bangladesh, July to September is peak, and finally there have no snake bite mortality at January to February, March. So here have the seasonal variation. and then I distribute this data accordingly our division and district. Some district has more snake bites such as Rajshahi and Kumilla, but the hill track area happens no snake bite mortality. So if we distributed this snake bite envenoming substance accordingly, we can get more profit or more result. Here the model of Sarima. 2022 2026 I measure every year the mortality incidence and predict the mortality which is occur and which will be occur and distributed the venom. Actually, we use the national MCCOD data, show that the persistent snake bite is rising. Not only the reporting, all of the government facility have access for MCCOD and they are have liable to give it. So this is, but every year it is increasingly, especially the monsoon season and clear monsoon seasonality and climate sensitivity. We see according to the temperature and humidity an upward trend through the 2026. So there have any significant not only the reporting but also the patient. Actually, my recommendation or conclusion is the data of the MCCOD, which is represent only 15% of death in Bangladesh, but 85% of the death isn't hidden. Some of the patients come to the OZA or get local treatment, haven't any medical certification or any other facility. We cannot address this, so we cannot represent the whole of the Bangladesh. Only the 15% of Bangladesh can represent this research. So if I get any other opportunity, I will do it. So it's my more limitation. And thank you. Thank you. It's my Bangladesh and invite to you Bangladesh. Any question?
Okay, thank you very much, Dr. Paven. Maybe because she had come to the end of her 10 minutes, we could just see where we get extra time. Then we can, please note your questions. We can ask at some point. Thanks. Maybe we move to the next one. I think it's Mr. Tan.
Yeah.
Hello everyone. I'm Long from Harvard University Public Health. And today I will to present my study on improving the road traffic injury surveillance system in Da Nang using the multiple data sources. First, I would like to acknowledge the support from the Vital Strategy and ECA, SCAP, and the CAT program, and my situation in Harvard University Public Health. For the start, as you know, the road traffic injury as a major global health problem caused about 1.2 million people deaths each year, and low and middle income country account for 90% the death. And in Vietnam has some leading road traffic injury and leading cause of death. And however, the current data system fragment and really heavy on police report. We often underestimate the true burden These are not incomplete data and may affect policy decision. My study aims to improve the accuracy of road traffic injury data by linking multiple sources. Especially, we aim to re-estimate the number of fatality and serious injury, and to better to understand injury patterns. For our methods, we conduct the retrospective study from 2023 to 2025. We used for data sources, as you know in the slide here, we have the hospital data and traffic bonus, and the ASIC mortality form and emergency center here. And we apply to manual record linking by and recapture them to estimate the true number of the case. At the moment, we just have the IRB at last 2 weeks, and we will start to collect the data at 6 months and writing a report after that. So for the result, we expected to that many cases will appear in one data sources, and with a limited overlap between data set. This will be success for the police. Data alone may underestimate of the number of this case. And we also expected that just estimate will be higher than police report right now, and other reporting may vary by age, sex, road user type. Common injury are likely to include head injury and injury, internal injury. And now my next step here and our timeline for the rest of our study. We will try to end the study of this year. Thank you for the attention, and thank you.
So I think you saved some minutes, so we can take questions for you. I don't know if there's any questions for Mr. Long. Oh, there.
Yeah. Hi. I think it's a interesting study, and I would like to learn about what is your definition about serious injury from the road traffic crash? Yeah.
We have some criteria from the serious injury in the hospital by document by the police, and maybe in the hospital the patient admit in hospital more than 24 hours and have some trauma care criteria when they admit in the hospital.
Thank you. Any other question? Okay. Okay. Anything online? Okay, maybe we can move to the next presenter. The next presenter is Dr. Abhishek. Yeah. Okay. Okay.
Hello. Yeah. So good afternoon all. I'll be presenting our work on enhancing mortality statistics by integrating the verbal autopsy in civil registration system in Tamil Nadu, a state in India. And I would like to begin by acknowledging the persons who made this possible. The leadership from Directorate of Public Health and Preventive Medicine and our collaborators, WHO India, Indian Council of Medical Research, National Institute of Epidemiology, and Institute of Community Medicine, Madras Medical College, And not last but not the least, Dr. Chalapati Rao from Australia National University. The key members from these organizations have been mentioned here. We all know that cause of death data is very important for public health planning, evaluating interventions. However, in India, the cause of death data is less than 24%. In Tamil Nadu, our state, we have a 100-year-old public health system and we have 100% death registration currently. And when it comes to the cause of death, out of nearly 7 lakh deaths, we have 1/4 of institutional deaths, which has 100% cause of death coverage. The real problem is non-institutional deaths, which is almost 3/4. We have almost nearly only 29% coverage. So there is a necessity to strengthen the cause of death. To address this gap, we introduced the verbal autopsy, and we also issued government orders to formalize the implementation. We assigned roles to the existing health staff and saw that it is pushed in with their routine than as a parallel structure. Now I'll run you through the methodology. 2 questions, where we did it and how we did it. First, where we did it. In India, the cause of death has to be registered, the death has to be registered within 21 days. It's a mandate. So once a death occurs, the death report is provided by the relatives of the deceased to the birth and death registrars in a form of death report, which we call as Form 2. So this death report, once in Tamil Nadu, what we do is when we receive the death report, it is entered online. And in this death report, there is a question, was the death medically certified? And in institution, it is a mandate to register cause of death, and we do it online. So we have a separate platform to capture the cause of death, and the registered medical practitioner, who's the person who attended the death, will give the cause of death for institutions. The real problem is with the non-institutional deaths, where it is not a mandate. So if it is a mandate, we again get the cause of death from the concerned doctor and enter it online. If it is not available, there what we did is verbal autopsy. So we did verbal autopsy with the local health staff, and with this data, again we went to the local medical officer who assigned the cause of death using a web portal. We call it as PCVA. And this data was merged with the existing data, and after merging the data, we did some data validations and data corrections, and we released the data. So this was not done for the entire state. We did it for 2 particular districts, Karur and Krishnagiri, and this was done during 2023. Now, how we did it? So coming to how we did it, so while entering in the death report, the data is automatically mapped to the residents. We collect 3 residents, permanent residents, usual residents, and the temporary residents. And in these 3 residents, we used to extract the data specifically to the permanent residents. And this data is extracted and we assign a unique ID. And this data with unique ID is populated into a ODK tool, which is a data collection tool. And this ODK tool is provided to each health inspector who is a multipurpose health worker of the concerned area. And we also give the data to the district. So what the district does is, they also give it to another health staff known as village health nurse. So the village health nurse fixes the appointment with the relatives of the deceased, identifying the correct person, and this is done after the grieving period after 6 weeks. So once the appointment is fixed, the local health inspector, that is the health worker, goes and collect the data after getting the informed consent. So he collects the data using WHO VA 2022 tool, and this data, which is incorporated in the ODK, has many validations. And after the data is collected, it is again put through our server, which is with the state of Tamil Nadu. And from this server, the data is again connected through another web portal, which we call it as PCVA. And in this PCVA web portal, the data which is collected by the health inspector is again comes to the review of the local medical officer. And in this, the medical officer reviews the data which is collected. I also forgot to say two things. The health inspector or the health worker doesn't only collects the data. He also collects the medical records and open narrative. Open narrative is something, the narrative provided by the relatives of the deceased about the last period of illness and how the death occurred. And we also have a separate validation tool for this open narrative. And this entire process is done under continuous monitoring and supervision for a routine percent of cases. And once the data is reviewed by the medical officer, it is submitted in the web portal under Form 4 VA, which is a specific form which also has validations and is coded to ICD-10 and ICD-11. I'll also show the screenshots. And after this data is merged by the state, again, as I said, we do the validations and then we arrive at the mortality statistics report. So now I'll run through the screenshots. This is the death report, which we called as Form 2. So you can see there is one thing known as was the death medically certified. So in this, if it is a no, this data is extracted and we assign a unique ID, and this is the data collection tool we call as ODK, Open Data Kit. And in this we can see the data is automatically populated by district, by health block, and comes under that primary health center. And in that the interviewer and the participant ID, which is the unique ID which I was speaking about. And this is the unique ID with the names. And this is in local language. Also it is in English. So you can also take in English and Tamil, whichever they are comfortable with. Sorry. How to go back? How to go back? Yeah. So, okay. So this is the format, and as I said, this is the person how we like to take. Is it in English or Tamil or other languages? Currently we have only English and Tamil. And this is the snapshots of the questionnaire, and this is just yes or no or don't know or maybe, and we don't have to write. So it usually takes 20 to 60 minutes, and we also have the validations for that. And regarding the medical records, we have not made it as a mandate, as most of the persons do not have medical records, but this we have taken as a quality indicator and asked them to review the data. And coming to the open narrative, it is a mandate record, and we have validations for this. And once the data is completed and submitted by the local health inspector, who is called the health person, it is automatically populated into the web portal every 24 hours. And this web portal, the registered medical practitioner is given a particular ID, and that he has to enter. And when he enters, you'll get the dashboard with the quality indicators and quantity indicators, and he has to select the line list, following which the entire line list will come from the health inspector. And in this we have multiple validation. They can select by pending status, by date of interview and everything, and they have to select the pending case. And once they select, the entire VA questionnaire is populated into 14 blocks. It is actually 12. Open narrative and medical records included, it is 14. So the medical officer has to go through each column. So you can see the tick mark. So only when he goes through the each column, he'll be allowed to generate the summary. And in this we have some validation. If it is a male case, the female cases won't come. So it's a male case, you can see the maternal death, delivering baby, pregnancy has been automatically disabled. So if it is an injury, the concern will be disabled. So you have multiple options, which is making comfortable for the medical officer. And once he sees all the columns, then he will be allowed to generate the summary. So this is a summary which he gets, and this is auto generated. He has not to do anything with it. So based on this data, he will be providing the form 4 VA. And these are our results. This is the quantity indicator. We can see it has increased from 42% to 98%. in both districts, Karur and Krishnagiri, we almost did around 15,744 verbal autopsies. And coming to the ill-defined causes, we all know that code R is specific for ill-defined. So it was around 50%, which reduced to 15% in Krishnagiri and 41 to 8% in Karur. Ill-defined causes, specifically I46, it reduced from 24 to 8 and 15 to 2%. And we also had these outcome indicators by the level of primary health center, not by district, by primary health center. Leading causes by age, leading causes by sex, and chapter specific causes, non-communicable disease indicator, years of life lost by cause of death, and the comparative analysis of ASDR, age specific death rate. And coming to the discussion, so the integration of verbal autopsy with self-owned government system can, without any external mechanism, is better for the integration, and it also led to improved completeness and quality. The main thing which we helped here is digital innovation with real-time monitoring and standardized customized dashboard supports and cascade training model. We had a multiple trainings and training of trainers, and that helped us. And last but not the least, monitoring and evaluation. So this is scalable as we tried in rural and kind of, we won't say it is an urban, it is a peri-urban area. And embedding within routine government systems increases the sustainability. And the operational lessons is we wanted to exclude deaths which occurred in postmortem, and we also want to provide the refresher training. So the key recommendation is to institutionalize verbal autopsy and automate the computational steps. Certain steps were manual, we wanted to automate it. And the next step is scaling the model across the state. Now we are going to add to 10 more districts and use the data for district level planning, which we have already started in those 2 districts, and evaluate the long term sustainability, cost effectiveness, and integration with other health information systems, which is on way. We are trying to do that. And thank you, and my contact is below.
Thank you very much. Thank you very much, Dr. Abhishek. Yes. Just wanted to be sure. Thank you very much. I don't know, is there questions? Okay. We'll start there at the back, then we'll end with you. Okay.
Good afternoon, everyone. I noticed that I observed from your presentation, you have various steps of, getting the data driven from one end to the other end. So I was wondering, who has the overall oversight of all these processes? Is there a kind of alert along the way? Someone is not doing that particular process, because it's moving from place to place. Different people are involved. So is there an overall mechanism that someone can spot something is missing, someone has not done their part in your process? That's about all. Thank you.
Thank you. Thank you for the question. So I think we showed a web portal, PCVA. So in that web portal, there is a indicator, and that indicator is for quality and for quantity, which can be accessed at the block level, district level, and state level. And we review it on a routine basis, and we also have meetings every month or bi-monthly, and we also review the quality, and we undertake supervision specifically based on the reports, and we ensure that the data is collected on a proper way, and if there is any lacunae, we do address it. Hope I try to address the answer.
I agree with you, but the point of inspection of the data happens at a later stage of time, right? So will there be any kind of lag in collecting of information along the way? Because you're only inspecting the data from the web portal at a different stage of time. So in between, what happens if there is some lack of important information?
No, see, it is all automated. So once the data is collected from the CRS, it is automatically assigned, and that is a manual part which we are doing, and that is done every month. And we in the state do monitor it. And from the ODK to the PCVA, it is automated. Every 24 hours it goes. And if there is any issues, that is again will be notified to the state immediately. And this system is monitored by a specific person in the state, that is myself.
Okay, thank you, thank you very much. Maybe you can take it offline for further discussion.
Yes, sir.
I'll take you, and then I'll take.
Yes, thanks so much for your presentation. And I really like the way your project implemented the WHO 2022, whereas the other countries are running away from it because of the cost that comes with PCVA. So my question goes to the process of the PCVA. It seems like there's only one doctor doing the PCVA, and on the other side, WHO recommends at least two, and then a third one in case the two don't have have a discordant. So I don't know how you handle that, and in case there's any discordant, what is the process of resolution of that discordance? And then number two, there's a point you mentioned redoing an interview in case there's any problem. So how do you preload the interview to be redone, or do they do a second one and then you delete the first one? Yeah, thank you.
Sir, second question I couldn't get properly.
The second question was, at part of your presentation, you mentioned that in case there's any problem in the data, you ask them to redo the
Yes.
VA interview. So I was asking, how do you preload the interview back
Okay.
so that it can be redone?
Okay.
Or you just delete the first one and they do another one?
Okay. So thank you for the question. So the first one is regarding the PCVA portal. So I know it is inform at least 2 doctors must do it. So first thing is we didn't do we didn't use any external persons. We used the persons who's within the system, and within the system currently we have only one person to do it. And for the validation part, which has to be done by the another, we are planning to do two things. It was not done for this, but we are planning as we are expanding across the state. So we are planning to try to bring AI, artificial intelligence, and to cross validate the cause of death which has been captured by the medical officer. So that one thing is being done. The second thing what we have done is the reports. So in the report we have the codes which are not to be put. For ICD-11 we take the MX14 codes. For ICD-10 we take the R codes. So if there is more R codes or the MX10 codes, we take the data and ask them to validate it properly. And if there is any issues, we ask them to redo it. Redo in the sense like we specifically ask them to collect the open narratives. We don't ask them to do the entire verbal autopsy because the verbal autopsy data doesn't changes. The main things what we request them to collect is the proper open narrative and the medical record if possible, so that the cause of death can be ascertained in a better way. Hope I answered your question. Thank you, sir.
I think we can you take the online one? Then we'll go to you, please.
Okay, I think it's a little bit along the same lines, but the question online is saying, this is a good example of using CRVS as the frame. Do you conduct a verbal autopsy on all home death? If so, why? And what is the status of MCCD Form 4A? And how is this linked to this process? And what is the expansion plan? How sustainable is PCVA?
That's a lot of questions. Okay, thank you for the question. And we are not doing for all home deaths. We are doing for the deaths which don't have the cause of death information. As in my presentation, you could see that we had around 29% cause of death. And verbal autopsy is not our main aim. Our main aim is to improve the MCCD. And when we are going for a verbal autopsy, we always insist them to say that it is better to get a cause of death form. So that is what we are doing. And regarding the expansion, currently we are expanding into 10 districts in a phased manner. So now in the next phase, we are currently adding 2 more districts district known as Perambalur and Tirunelveli, and remaining will be four districts in the consecutive years. And this expansion is done with support from ICMR NAE, and we are doing it as a implementation research. And while parallelly, we are also seeing other sources to expand it to the other districts, and we are trying to get support from the central government and the state government. I think I answered all the questions.
Okay, yeah, thank you. Okay, I'll take them, then I'll take her, and then we can move to the next
Yes.
speaker. Yeah.
So actually, my question also a little bit refer to his question as well. So I just wonder, you use the 2022 instrument. So why you don't use the CCVI? You only apply for the PCVI. That's the first thing, and you in the business process, you also have the process up to the VI, but do you have some kind of procedure for the how long from the death to the time the health worker need to conduct the VI? And the third one, when the interview, you mentioned about the open narrative and some of the medical information, such kind of information you collect from the family or from hospital, and how many percent of the case you can accept for such kind of information? Yeah.
Can I ask that we just have one question so that we'll have another round?
Okay.
We still have another.
So the medical records we don't have as you had, and it is just less than 25%. The medical records, and we don't use any online versions. We go them and ask whatever they have in hand. We take a photograph and upload in the portal. And verbal autopsy. And the other question was regarding
the date.
Yeah, death timing. So the data we upload it in the next month itself, but we gave them a grieving period of 6 months. The maximum we try to push it before 3 to 6 months so that they don't forget it. And we also have routine monitoring and ask them that if there is any cases pending, we instruct from the state and the district to complete those cases first and then go to the remaining cases. We try to get it completed within 6 months maximum, and starting is after 6 weeks.
Okay, no, thank you.
CCVA, we are currently going with PCVA and WHO automated tool. We are planning to integrate DORIS with the existing system. That is what we have planned. CCVA, we are maybe for a study. We are planning for a study, but as of now, we are not planning to move to CCVA. We are going, and these two different portal also we are planning to integrate within the existing CRVS. Instead of having two different portals, we wanted to bring it as a one portal, and that is a work ongoing, has not yet completed. But plan is to have the entire thing into a single system, and that is what we are working on.
Okay, I'm going to propose that we take the next presenter, then the rest of the questions can move. Yeah, apologies to the others. Okay.
Thank you so much. A good afternoon, a good evening, and a good morning back home to Uganda. I have my fellows and my colleagues that I know they are online and they are listening in. Yeah, I've already been introduced, but that's me, Yefta Remwa, and I think since I'm my last speaker, I wanted to use a lot of minutes. This is just like a summary of what has been happening, but intuitively, I dived in this to find out that how can we use the existing, whether little or much, verbal autopsy data to see whether it is currently communicating anything as far as our cause of death and epidemiological statistical situations happen in Uganda. Point to note, this is not showing overall Uganda. This data is just from one HDSS in Uganda, and it is just covering two districts, as we shall see as we go forward. So this is just a debrief. We know that low and middle income countries like Sub-Saharan Africa, we are still seeing mortality disparities, as well as with the emerging double burden of disease. We know previous years we have been having infectious diseases, but in some settings now, the NCDs have become to be rampant. And according to the last report of WHO, the NCDs are estimated to be causing around 70% of the entire globe death. However, this is like a weak link within the civil registration and vital statistics systems in such settings, but countries have leveraged on using verbal autopsies in correcting community deaths or deaths that happen in the communities to see how they can mitigate this, because like in Uganda, over 60% of deaths happen outside the hospital setting, and this means that they lack medically certified certificates. And as I said, verbal autopsy is a widely used tool, standardized tool by WHO. And in Iganga Mayuge HDSS, we are using 2016, and currently we embraced the 2022 version. So my study is going to look at verbal autopsy data corrected over the years since 2005 up to 2024. And it is just looking at the mortality disparities and the status. So that is where everything we are talking about is happening. You can see that is our small country, Uganda, and these are the clusters of villages that cover the HDSS area. In total, we are covering 65 villages in 2 districts in eastern Uganda, and it is just a few kilometers, like 120 from the capital, Kampala. Currently, we are making a follow-up of around 100 individuals that are actively under a follow-up, and 52, almost 53% of them are females. Those are the events that we follow up, and our main interest is on death. So far, since that period time, we have registered over 8,800 deaths. The pre-2018, I have to make more emphasis there. From 2017 backward, we were not using inter-VA or verbal autopsy deterministic methods to determine cause of death. By then, we were still using a physician-coded verbal autopsy. And by then, records of death that happened by then make a 67.6%. We started implementing verbal autopsies in 2018. And out of that, we have so far registered deaths in the community, 2,847, making a percentage of 32. This is the methodology that this study used. This is a retrospective analysis. And one, we used inter-VA to determine the underlying cause of death. Inter-VA is an automated algorithm in OpenVA. The software engineers in the room can expound more. However, we merged the PCVA that was done before 2017. We got the cause of death assigned, and we just appended the underlying cause of death that was done after 2018 to get a full list of the VA records that we have looked at. Then after that, I went ahead and I grouped these causes of death, specific per individual, into the 5 major classified causes of death, major categories as they are grouped by WHO. That was infectious and parasitic related death, non-communicable diseases related death, maternal, neonatal, and nutritional conditions, injuries, and determined conditions. Everything was done in R, and we also checked for temporal trends to see whether we are having the transitions. You remember one of the questions we went out to wanting to answer. We want to ascertain whether we are seeing anything that is being communicated in this. We also looked at how many years of life lost that can be attributed to this. So before looking at all the graphs and the charts and all that, there is something in the upper right corner. Where does this death happen actually? in this cohort, 62 almost % deaths happen in the community. These people die without visiting the health center or health hospitals. And only 34% are able to die in the hospitals. And we are having about 4% of individuals who die on the way to the hospital or on the way to seeking care. Now, this analysis considered the 799 deaths. The simple descriptive of death, it was the median age was 32, and the overall year life. The first chart, bar graph, looks at cause-specific mortality fractions. These were generated after running the CMFs in R, but we grouped them by bandwidth. We categorized those years to see whether there have been movements over time. That is a bandwidth of 5 years, and you can see that the infectious diseases related death have declined over time. We can see like in 2005-10, it was around 45, and in 2017-22, it has reached around 35. That is like a decline of almost 10%. And what are the interesting statistics from this? We are seeing the non-communicable diseases shooting. We can see that it was around 28% in 25 to 2010, but now it is almost approaching 40%. Interestingly, injuries, they have picked up. There is some interesting story there. Injuries related deaths are increasing over time. We went ahead and we disaggregated because we wanted to make differential statistics or analysis. We picked between infections and non-communicable diseases. We just looked at the two categories. And when you look at the proportions of deaths that are attributed over time, we can see that currently the NCDs are overtaking the non-communicable diseases, looking at the bandwidth. So these are the temporal checks we did. If you look from 5 up to 2022, from the beginning, the infectious were dominating over other categories. However, when you look closely from around 2018, the non-communicable diseases have surpassed all other death categories. But there is something interesting when you look at the green line, and that is the maternal neonatal. We are losing a lot of mothers and babies since 2020 to 2022. We went ahead and we used the stacked bar graph to look at the distribution by age group. Now we are entering into the disparities or the differentials, because this paper had 2 sections. We are seeing that infectious diseases by blue bars are being dominant in children and females. However, when you look closely on the purple color, those are the NCDs. We can see that someone easily can say they increase with the increase in age. However, there are some interesting patterns. Like when you look at young adults and the reproductive age, NCDs are doing to us a disservice. We are having some potential proportion over there. When you look at the green bars, those are the injuries. You can see that we have a lot that we need to concentrate on in those categories. So we also looked at the classifier by sex, and we see that when you look at infectious diseases, we're almost having same proportions, and the non-communicable are more in females. I think there's a lot of story to dig up there. As well, we clustered, this is age, but we just grouped into 3. Maybe I can talk about this during the question session, more about this chart. It is interesting. However, what does this tell us? We are seeing that NCD-related deaths are dominating mortality in this cohort. However, is there anything happening in other parts of Uganda? That is a question to each one of us or to my other colleagues in Uganda. We can also see that infectious diseases are still contributing substantially to number of years people lose without attaining their life expectancy. And we had some limitations, like this is limited data, we cannot conclude and generalize entire country. As also we never had the opportunity to dive in and do individual risk factor analysis. And now what do we speak or what do we want some agencies to do? The Ministry of Health in Uganda should strengthen early screening of NCDs at lower levels, like districts and other health centers down. Also, there is a need for different stakeholders to strengthen data linkage because this is hosted in one HDSS. And these statistics you can find, maybe they're missing to be communicated by Ministry of Health. And in conclusion, we are seeing that we have health inequality responses that need to be mitigated in terms of gender and age. Also, there is still a double burden of disease. What are the next CRVS priorities? We need to conduct further research because we have seen some patterns that need to be investigated further. And also, the government should harness and support such settings, the SDSS, because I think they communicate something to public health. And also, I need to link different systems in the country across the stakeholders, agencies. I thank you so much for listening. Thank you.
Okay, thank you very much, Yehu. Maybe now, maybe let me start. If there's any question for Yehu, then we can open the floor for others. Okay, go ahead.
Thank you, Yahoo. Thank you for the nice presentation. Particularly, it was really very nice, and you showed a lot of things. As a friend, I will first request you, if it's not that much essential, please give us less pressure so that we can understand well. Okay. My question is that it's your slide number 1, 2, 3, 4, 5, 6. In the sixth one, you showed that the maternal, neonatal, and nutritional conditions related deaths increased drastically from 2017, 2018, 19, 20. This was a little bit more or less okay. But in 2022, it just grew uprise like a rocket. So, did you try to address this? Why this happened?
That's all I can take on. Yeah, for example, there is an assumption we cannot ascertain. I think that's why I said there's further research that need to be investigated. However, if you look at other literature, this is a little earlier setting, and we suspect because when you look from 2020 upwards, between there was COVID time in Uganda. And in Uganda, we had a different kind of scenario whereby I think in the whole world, we had the longest lockdown. So this is a low area where teenage pregnancy is still high. And we anticipate that there was no free people accessing care, young children becoming pregnant and not getting enough care and all that. We are seeing there's another analysis I did, maybe we shall discuss. We are seeing number of stillbirths being rampant around 21, 22, and we suspect there must be something there. And I think these numbers can help policymakers to see if such conditions again rise or come up, what should be done better.
Thank you.
Okay,
Thank you for the question.
Can I ask him? 1 minute, please. Do you still want to ask your question?
Okay. Thank you for
My name is David Adombiri from Ghana. Thank you so much for your insightful presentation. This is really interesting, but it's quite intriguing. Some of the results that I'm seeing here seems to defy the norm. I'm wondering why you have most of the deaths that you reported that females really face the high burden of non-communicable disease. Do you try to find out why more women are dying from non-communicable diseases as compared to men? And then also, it seems to suggest that the next slide, you still have females, the undetermined deaths. The female seems to be recording more of the undetermined deaths. Is that the case? No. Well, okay. So yeah. So let's deal with the non-communicable disease. That was. Did you try to find out?
Okay, thank you so much, colleague from Ghana. With that, in this, I did not dig deep to see what are the exact specific individual causes that might be accelerating that. However, it is something I can look up to as I'm trying to finalize it, the manuscript or the paper to be out. I might need to look at that, and maybe I can discuss it in the discussion section.
Maybe what we can do is to open the floor for all presenters, and also noting that for earlier speakers, basically Dr. Pavin, we didn't ask questions. So if there were questions for her, maybe we can take them, and for Dr. Long as well.
Thank you to all presenters. I have 3 observations. One for the last presenter. If you go to the third last slide, just go up. There's a conclusion. Just go up again. Yes, that one. Where you are concluding that sex, age, and area of residence and the wealth quantile are crucial for assessing mortality disparities. This study is in a rural setup. So when it comes to the area of residence, which other area do you consider? Even the wealth quantile, I've not seen any discussion on the wealth quantile in your paper. So maybe you may need to comment on that, whether those 2 variables, you also process them in your data that you presented. Then the second presenter on the climate sensitive rise in snake something. So from the title, I was expecting that we see the rise due to climate change or climate something, because that's what to me the title is suggesting, that the snake rise is due to the climate change or something. But your focus on the increase or the rise was basically on the last 2 years, 2023, from 97 to 121. That's where your discussion majorly focused. So maybe you may need to think through whether you need to change the title to the impact of climate variability on snake bite mortality, because your discussions were on variability across the year. When you are having the cold, those seasonality you were showing. Then I was wondering whether there is variability by sex, because you were giving the totals, but I don't know whether you analyzed Is there any variation by sex, especially now that you mentioned the age 20 to 34? We'd be interested to know whether in this age 20 to 34 that is the numbers are high, is it a males or female who are mostly affected? Then there was another one on the road traffic. That's the last one. On the road traffic, which I think is proposing to do, I have one observation that you made. You indicated that the sample size, you are going to select 10,000 from each of the 4 sources. And then you indicated that each case is going to be unique. You expect to have unique from each of them. That means you're going to study 40,000 cases. So I don't know whether the viability of that, and then how to ensure that the cases are unique from the 3 sources. Then maybe will you consider variability across the year? Because some people say that across the year, the cases are high, either some places towards December, some places at the start of the year. So would you like also to look at that in your study? Thank you.
Thanks.
I think
Maybe you.
I think my question was first from Mose. Yes. Thank you so much. A good catch. Yes. The HDSS is predominantly rural. However, we cluster it into just that I didn't highlight it in my description when I was showing its setting. It is rural and peri-urban. We have some kind of urban element, but it is dominantly around 67 rural. Then the various quintiles, yes, we do carry out surveys assessing the socio-economic status in terms of assets each household has and everything. So we use PCA to calculate and we compute the quintiles from the household level data. So that is what we used. Thank you.
Okay, thank you.
Yeah. Thank you for your nice question. Actually, I get this data from the SIS2 of DG Health under the Ministry of the Health. Here implemented MCCOD system covers all of the government institute in Bangladesh, include some private. From 2019, I extract this data from 2020. So the coverage is almost all of the heart same, but the number of the snake bite death is increasingly. So I want to find some factors such as linked to the climate change, such as the humidity, rainfall, and any others. Then I try to get this data from NASA Power and analyze. There is a relationship between the months season and humidity, such as the monsoon, especially the monsoon, where the rainfall and snake come to close to the human and they bite. Your second observation, male and female. Obviously, in Bangladesh, male are more work in the agricultural field, so they are close to the near the hole of the snake or any other source of the snake. So male are more predominant than the female. Thank you. Would you get your answer?
You can discuss outside. Thank you.
Yeah. Yeah.
Okay. Okay. Is there still some more questions? Okay.
Thank you. I think I had the same question for you, but I am happy you ended on the fact that women are more predisposed to farming activity. Is that the case you are making? That's why they have the snake bite more than females, the males.
Yeah.
Okay.
Yeah.
How about the 20 to 39 year age group that you suggested that they face the high burden of this snake bite. What is so peculiar about individuals who are 20 to 39 years? I don't know if you get the question.
Please repeat your question.
Okay, so my question is,
Or
you made a statement that individuals who are 20 to 39 years, they seems to be the people who face this problem of snake bite. Why?
yeah, I get this data from individual, case to case.
Okay, so I want to understand why he is 20 years, I'm 39 years. Why are we more?
Yeah. Thank you for your nice
get
question. Yeah, I understand. Actually, the young people are more work in the field. Bangladesh is an agricultural country. 80% of the people engage with agriculture, especially the male.
Okay.
And so the young people come to close contact with the snakes or sorts of the snakes.
Okay. So
Yeah.
that was what I was thinking for the females too. Do they also get in contact?
Yeah, no,
than
in Bangladesh context, female are working at home usually.
Okay.
Many of the male work in the field, and female mostly are housewives. So they are work in their home, and they clean all of the things near the home or outside the home. So snake are not from that.
But the presentation really shows that females, comes in contact with snake bite than males. Yes,
Okay, maybe can you show
the
the slides?
slides, yes. No, she mentioned it in there.
Mine is a long slide. Yes, back.
Is it?
If they have, that is wrong. No.
Particularly,
No.
if you don't mind. Particularly, I am also correspondent of this study. Particularly, we didn't focus on sex. Okay, because we really wanted to see three things here. Number one, does the mortality occurs across the time the same in different season of the year? If it has any relationship, we try to find that. Second, is there any relationship of the total death due to snake bite is associated with some climate related factors like temperature and humidity?
Okay, no, thank you very much. I think it was yeah. Okay.
Yeah. So I was I don't know if I may not be getting 696,000 deaths in a year. Yes. Wow.
And it is all registered in our civil registration system.
Wow. Okay.
When I was in China and I told that I attend more than 200 patients per day, all the participants, are you right? So they have huge population.
It was 9 lakh during COVID.
From the Philippines. We were quite surprised that these huge numbers were coming from like recorded in 1 year, and we're like, is there any peculiar issue? Is there a pandemic?
No.
It was registered, and almost 99.99 were from the same year.
Okay.
So there are some late registration, but of negligible numbers.
Okay, can I request you to take the discussion because now you are. Yeah.
From Uganda again. You made mention about the years of life lost. Did you do any life table modeling? Were you able to collect information from these participants? Maybe the years they have had, maybe this non-communicable disease or communicable disease before dying, and you are able to estimate the years of life lost. I didn't see it in the paper, but I don't know it.
All right. Thank you so much. Actually, I think that's why I have been battling with time. This is their preliminary results, but in the full write-up, even what you talked about, the segregation by socioeconomic status, everything is there. I just cropped out something for presentation. But yes, we did years lost. We used the collab Demini life table method, whereby we looked at someone's year at death. From the death of birth, we computed someone's death years at death. Then we used the national recorded life expectancy from UBOS. We computed and we came up with that.
Okay. No, thank you, colleagues. Yeah, apparently we still have time. I was not sure. Yeah, I actually cut you. Maybe I can give you.
Answer him to my question. Yes,
Yeah.
him ask me the
Yeah,
question.
thank you. Yeah, okay, go ahead. Yeah.
Yes, because first, thank you for your question. But we have 10. I estimate a 10,000 case represent on each sources. As you know, but the 10,000 case represent a total case of record or each sources, upper sources. We include both the fatality and serious injury. So that is not on unique that not on separate case by the by the sources, and we want to link a study where we determine the overlap between the another sources and see the how many cases we unreported by police and or hospital. And we also study variable over time using variables such as age, name, accident date, and gender for comparison and classification. Thank you.
Okay. We still have some. If you can go ahead. I think you can go ahead and ask you.
Okay, this is just a very simple thing. My question is to Abhishek. That you told that first the death get registered, then you conduct verbal autopsy, right?
Yes.
Okay. Then so if the cause of death changes, because during death registration, do you enter the cause of death? You enter the
No.
cause of death.
That is for institutional deaths. And so this verbal autopsy is done specifically for deaths which are not having MCCD.
Okay, so without MCCD, those death occurs, you don't mention any cause, right?
No.
Okay,
And they undergo verbal autopsy, and following verbal autopsy, the local medical officer, who is a registered medical practitioner, assigns the cause of death using the web portal, and this data is merged with the existing MCCD data, and then we arrive at the mortality statistics.
Great.
Thank you.
Thank you. I really want to communicate with you more because Bangladesh is going to develop same things.
Always welcome, sir.
Okay.
Oh, thank you very much.
I have a question. Okay. Yeah, I have a question for Abhishek.
Yes.
So, Abhishek, hi. We
Hi.
met in India and I asked you the same question, but again, I'm asking you just to clear again. So, these verbal autopsy deaths are registered deaths or not registered deaths?
Okay, thank you for the question. We have some numbers, like say some maybe in two digits, around 12 to 20. So those deaths are unregistered deaths. Remaining are all registered deaths. So we just didn't want to leave anyone behind. So what we did is we also took the data from the maternal death register and infant death register, and we cross-verified whether all the deaths were included, and we found out some deaths, the same numbers were not included. So what we did is we assigned a random number and we made the verbal autopsy, and also parallelly we made them to register it.
Okay.
So in over it is a registered death.
Okay,
But
so
we found that and we made them to get registered again.
yeah, so that is what I wanted to know. So those dates are not registered. You like encouraged them to go to
Yes.
register the dates.
Yes.
Okay, thank you for that.
Thank
you
you.
so much.
Thank you.
Okay, thank you.
For
Anyone?
I have a question for you as well. So looking at the business process map, it seems to me that the notification is embedded in the MCCD form, right? The MCCD form.
Yes.
Yeah. So in your country, in your study, in your country, notification, yeah, is embedded in MCCD.
Yes, it's not in the country, it is only in the state. So we have specifically done in our state, not done in the country. So we have, before it was two different systems. Civil registration system was separate and cause of death information was separate. So what we did is we embedded within the system. We have a system that birth or death must be, the certificates must be given within 21 days of the event. So what happens before was they used to give the form for death report. They give the form 2, and based on the form 2, they used to give the death certificate. And this MCCD was a parallel manual copy. So what we did is we embedded inside this using the option which I showed was the death medically certified. So if it is a medically certified death, they have to mandatorily enter the cause of death in a form online form 4, and after entering the form 4, these both form 2 and form 4 will be validated by the registrar. So validation, he will do the general validation, only the name, age and gender. And then he will give the death certificate. And in death certificate, we don't mention the cause of death.
Yeah, I think overall it's great. Yeah, I think I am very impressive with this work. It's well done, I think. Yeah.
I am proud to say that only in our state we have integrated this cause of death information with CRVS in the for the whole state. There are many other states, but they have not done it for the entire state. They have done in only in bits and parts.
Okay, thank you very
Thank
much.
you.
I think we have another question.
So I have a question for Mr. Yehu. Yeah, you have very nice visualization for the data, but in lens of programming, when I also saw you have a lot of recommendation for some kind of policy implication. So actually, if the data we visualize with by combine too many the grouping like the NCD. NCD does combine many kind of the disease. So so what is I think the people more concerned the policymaker because they need prioritize for very specific. So I don't know what it could be you want to show for all the reason to share in this workshop, so you don't make or specific very detail for any kind of the NCD, but you just to group by this one. That my concern and any of the what is called the reaction when the raw recommendation come out. Yeah, thank you.
Okay, thank you so much. It's kind technical, but I think for the purpose of this, that is the kind of design we wanted to show. And also not to work, because I can imagine a graph showing all different categorization at an individual level. However, there are different ways we can disseminate this. If at all we are targeting, let's say, policymakers from Ministry of Health, they would be interested to know which kind or which particular cause stayers death than the other. And we have the data, we can disaggregate that, and we can break it down like in a brief, policy briefs, simple things. But here, I didn't go into all those details for the purpose of this output. But that can be done in different dissemination formats for policy and recommendation purposes. Thank you.
But any output from them so far? Any, you have get any of the response from the government or something? For example, you mentioned because the NCD contribute and increase more, so you recommend that they need to apply for the NCD in primary care, right? So breast screening is quite different with other screening for the cancer, something like that, or the, something like, okay.
All right, thank you so much. Maybe something to note, this is work in progress. This has been my project for CAT Cohort 2. We are still developing a paper, it is not yet published, but I think so far it is communicating something, and we haven't engaged any policymakers or even government.
Okay. Okay. No, thank you very much, colleagues. I think it looks like everybody's happy now for questions asked. Okay. Okay. Thank you very much. Thank you very much for my presenters. It was such a lively session. Just one question. So I think most of the questions I wanted to ask were asked. So to Dr. Abhishek, when you talk about scalability, you seem to talk to the geographical part. What about the cost?
Cost.
Yes, scalability in terms of cost. How practical is it? And I think my other question was around whether or not with this there is also registration, because you seem to indicate that you only deal with those that were already on your system. What about those that are, because I think your level of registration was around 22% or 45%? I don't remember. There were two figures.
So the numbers before, what we had in Karur and Krishnagiri was 27 and 42. We pushed them to 98%. And routine cause of death is around 44%, especially when it is non-institutional death, it is that 29%, 29 to 25%. And coming to scalability, those two districts we did the support from WHO, and main issue will be the manpower. So this, as it is within the existing system, so the manpower, you don't have to spend much for manpower, just the trainings. And trainings, we do the TOT. So with the TOT, we train them at the district level. So there is a cost cutting there. And also what we did is the software part. It has almost been made ready. There are only some things has to be updated, and that also is done within the system. So most of the things we are trying to bring within the system so that the cost is mostly cut, and the only cost which I see is training. And we have provided actually tablets for the health inspectors for the data collection, which can be done in your own mobile phones. What you basically require is an Android mobile. So the only cost I see is training, and that too we are trying to see the online models. The only thing I don't know how effective it will be in online model. So we have seen that it is a cost-effective model.
Thank you very much. Thank you very much, everybody, for the active participation. I know it's very late in the forum, and people are now anxious to leave. I really appreciate it. Thank you very much to my speakers. I think we need to give them a round of applause. Thank you very much. I think we can now close the. We don't have anything online, eh?
No, I just wanted to give some practical
Okay.
information. When we finish here, there'll be coffee break in front of CR3, and then we will have the closing session in CR3. So please